My name is Dave Fuhrer. I am the CEO of Grit Health and a cancer survivor. We are proud to welcome you to this 20th, if you can believe it, live session of the COVID Advocacy Exchange. Today's focus is addressing gaps in healthcare through real-world advocacy. And this is also National Minority Health Month. And so we are going to dig into a really powerful and moving panel and then have a report out and conversation with our 4 working group leaders who are each leading change in areas that this group has said is a priority. When I think about this week last year, if we can all remember what a year ago was like, our team was literally constructing this platform, the programming, all the behind the scenes, and to see how many connections and collaboration and all the things that are happening now this year later. It all started from a BMS idea, and that was to connect us as all of our in-person gatherings and the ways that we did our work were ending, and COVID was upending the ways that we needed to get our job done. And so this platform, this COVID Advocacy Exchange, was designed to create connection, to bring us together to solve problems, and to capacity build across our organizations. And so I just want to start with a heartfelt thank you to BMS for believing in that idea, and to everybody now who has brought this to life in the way that it has over the last year. So the first thing we will do before we get underway is have a welcome video from Danielle Hallstrom at BMS.
I'm Danielle Hallstrom. I head commercial communications and patient advocacy in the corporate affairs function for Bristol Myers Squibb. I'm thrilled to be opening our discussion today on addressing gaps in healthcare through real-world advocacy. As some of you might know, April is National Minority Health Month in the U.S., a time coupled with many others throughout the year to raise awareness about the disproportionate health burdens affecting minority populations and encourage action through health education, detection, and control of disease. Today's session will keep this in mind as we focus on representation, an integral part of providing equitable health services to all. This afternoon, we will be joined by a panel of advocates who are recipients of Bristol Myers Squibb's grants to advance diversity, inclusion, and health equity. They represent a few of the more than 50 patient advocacy and community-based groups, health equity coalitions, medical societies, nonprofit healthcare institutions, and other recipients who were identified following completion of a special request for proposals last year. These advocates and the organizations they represent are taking concrete steps to enact change and support medically underserved populations in the U.S. through disease awareness and education, helping to increase diversity in clinical trials, and providing better access to care and support for patients. After we hear from some of them and learn a bit more about the projects they're working on, we will also have an opportunity to hear updates from our COVID Advocacy Exchange working groups. These groups kicked off 2 months ago and focus on creating tangible outputs related to supporting the future of advocacy, patient-focused drug development, addressing racial and ethnic disparities, and improving access to care. Just a reminder that these groups are meeting throughout the year, and there's always room for more voices to join. So if you're interested in continuing the conversation after our session, please let us know. With that, my hope is that through today's gathering, we will each walk away with some new information and ideas about how we can better support all patient communities. So on to the rest of the session. Over to you, Dave.
Thank you to Danielle for those welcome words. The individuals that you're going to meet now in our first conversation this afternoon are health equity advocates, champions, and leaders. And in our prep conversation for what we wanted to share, we will talk about best practices and lesson learned and the things that they're doing to create real change, but also some of how it affects them and the ways that they navigate challenges and stay inspired are such a huge part of this. And so we encourage everybody to add questions in the chat, be active participants in the conversation. And we hope that this panel really helps kick off what we move into with our working groups and all of the change that they're creating after that. So our first panelist that I have the deep honor of introducing, and I see him at the bottom of my screen, Reverend Anthony Evans, is the president of the National Black Church Initiative. And I hope we'll all welcome Reverend Anthony, and please introduce yourself and your work.
Yeah, can you hear me? Good, wonderful. Reverend Evans, president of the National Black Church Initiative, a coalition of 150,000 Black churches in the country that we work and facilitate health programs, which makes us the largest faith-based health initiative in the nation. I'm very proud to tell our panel that of one of many defeats that we have achieved is that we have created a comprehensive COVID vaccine plan for the entire 150,000 Black churches. And our goal is to vaccinate 106 million African-American and Latinos, which will be 1/3 of the country. So we are working in concert with state governments, and anybody who will work with us to achieve that goal so that we can make sure that Blacks and Latinos are not left out of this critical vaccine, which is critical to the future of our nation.
Reverend, I'm excited to tell you that after we sent the information out, one of the advocates sent me a personal email and said, can you please introduce me? Because I want to support his work. So there's people here that are eager to be a part of the conversation.
Very good, thank you.
Yeah, honored to have you with us. Our next equity advocate leader is Tanya Ryder. Tanya is the Director, Diversity, Equity, and Inclusion at NAMI, which is the National Alliance on Mental Illness. Welcome, Tanya.
Hi, thank you, everyone. So NAMI, the National Alliance on Mental Illness, we're the largest grassroots mental health organization with between 650 affiliates and state organizations. And we've been around for now almost 41 years. And we started off with two moms at a table having a conversation about concerns about their sons who were experiencing mental health diagnosis. And so we are about healing, about advocacy, education, and programming to support all of Americans right now, because we're all dealing with some type of mental health issue, whether or not we have a diagnosis. So thank you very much. It's an honor to be here.
Thank you so much, Tanya. Excited for the conversation with you. And our third panelist, who I'm honored to welcome, is Venus Guinness. She is the CEO and founder of Dia de la Mujer Latina. Venus, are you here with us?
You can hear me okay? Great. Yes, it's a pleasure to be here among all of you, the giants of our community that are doing such great work in your communities. Thank you for giving me this opportunity to share what we're doing here in Houston, and not only in Houston. Dia de la Mujer Latina was born out of my experience with breast cancer, my sister's untimely death to cervical cancer, and my brother who died of Hodgkin's lymphoma when he turned 50. And my goal was to really get the information out to our Latino community about what cancer was all about. But then I realized that there was a lot of issues with mistrust in our community. And for this reason, we started a program in 1997, Dia de la Mujer Latina. It translates to Day of the Latin American Woman, where we give her everything she needs as far as screening. So we provide the breast and cervical cancer screening, diabetes screening, but then it turned out to be more services that we were providing. We had our first promotora community health worker training and outreach in 1997. We are also going into our 25th year of celebrating this wonderful group of promotores and community health workers that are doing such great work, especially now with COVID. And one thing that I wanted to raise in this group is about misinformation and how important it is for our community health workers and promotoras to be trained on how to be able to debunk misinformation and the infodemics that we're going through in this country. So I don't know if we have a chance to show the short video now, or is that later? Dave?
We absolutely can, and Ben will bring it on now.
Okay, this is a part of our BMS training program.
No más, no more.
No more can we allow rumors, lies, and false claims to harm our communities. It divides us. It weakens our institutions. It can kill us. We must fight back with the people we know and those we trust, because knowledge is power, and with knowledge, we empower our communities.
We say no más, no more.
We unite against misinformation.
So as you can see, the whole project is revolving around the consequences of misinformation, whether it's misinformation about COVID, about clinical trials, about the vaccine, about cancer. We just need to say no más, no more. And as a community, multicultural communities, we stand together and united. And we are having our conference on Friday, April 16th, in celebration of Minority Health Awareness Month. The governor of Texas gave us that day as Community Health Worker Day in Texas, and honoring the work of those people in our community that are doing so much in debunking misinformation. And again, our goal is to continue our work with our call center, which is part of the BMS proposal and grant funding. And we are going to have a call, we're calling it the Telehealth Community Navigation Contact Center, not a call center, because we want to make sure that we have that personal touch, that contact, and the warm transfers that we're going to be able to provide with our people who are calling us for any kind of verifiable information or access to resources. And that's our goal with this project.
That's wonderful. If you want to put any information in the chat for people to check out or help spread the word, please absolutely utilize that. If we could, Reverend Evans, jump right into with the enormity of these issues, how complex they are, and for real reasons, right? Nobody's making these up. These are really complex long-term challenges. How do you navigate all that and try to inspire and affect so many people?
Well, the first thing we do, because we have, of the 150,000 churches, 27.7 million members, we find out what our members need. And we zero in on the needs of our members. And congratulations to my colleagues in terms of debunking misinformation. And because we are going through that right now. This project that we are have launched in our COVID initiative, we have 2.5 million volunteers, and they are literally going by door to door, trying to dissuade individuals believing that, that COVID was something that Bill Gates thought of, and he want to put a chip in our arm, and all of this crazy stuff, and also providing education and moral persuasion are two powerful means of making sure that our community is well kept and well informed.
May I ask how that is on your shoulders? How do you handle all that?
Well, our thing is that because the church have traditionally understood the weight of information. So even though that we were not supposed to take on the role of being the chief advocate for the African-American community in terms of COVID, is largely because a number of our national organizations never stepped up. That's really the issue. And they have departmentalized their particular discipline right now to deal successfully with any disease state, whether it's COVID or anything. You need a comprehensive plan. You need a strategy, and you need goals, and you need objectives, and you need to deal with the whole point of education. And in this case, we need to deal with education and disinformation. So it fell on the church. The church took the responsibility, and now we are making sure that all those entities in our churches, the Black community is unique insofar as the fact that we have everybody in our congregation. We have all the fire people in our congregation. We have all the police folks in our congregation. So we don't have to scream at the chief. We can contact the chief because the chief is a member of our congregations, and to tell him how we feel about certain things. And so we do not hesitate to utilize our moral persuasion with everybody. In this case, because of our healthcare workers all in our congregation, and through our HED program, our health emergency program, we thought of this 20 years ago, we're able to provide critical on-time education and outreach, and also get from them what we need. So every individual who is connected to the healthcare industry reports back to their pastor as to what's going on and how to navigate around that. So we have to organize within an organization, and that's avoid the disinformation that may come even from our media, who may not know exactly how to explain that. And certainly I think CDC underestimate the challenge of communicating this disease to the American public, and we have seen the missteps there. However, we are constant in touch with CDC to get it right and then spread that information. So we do what we got to do.
Well, wonderful. When I think about the COVID Advocacy Exchange membership, many of us are disease advocates from a specific area, some of us from multiple areas, and some of us work across all of these healthcare areas. I love that you are using faith, leveraging faith to allow better connection. Tanya, that feels like such an important connection to how mental health cuts across all of these areas. So how is this on you, and how are you tackling the enormity of all this?
Well, as we know, there is no health without mental health. That is such a big part of who we are. And, I want to bring in what Reverend Evans was saying, about faith. And we look at that we are comprised of, there's different parts of us. We look at dimensions of wellness. Spirituality is a dimension of wellness. Our mental health is a part of that, our physical health. And so we're looking at how do we best provide education and resources. And really, we look at our strength is in our numbers and our grassroots. We're going back to that. How do we connect with our communities? And we're really looking at, really from that equity lens, what is it that the community needs right now? What are those specific needs? And so being able to have those connections and those bridges in the community, and working with promotoras to be able to talk about the importance of mental health in your physical health. And so we're looking at that right now and figuring out how can we best equip our affiliates and state organizations with more information, with resources that are going to help them, that are going to equip them and empower them to help the communities and really provide what the community needs. And, it's not always, thinking about a great idea and saying, hey, this is what we think the community needs. We need to listen to the needs of the community and ask them, hey, what is it that we can do? So taking the time to have those community conversations and going out there and saying, you know what, let's just sit down and have a conversation. And right now it's through Zoom, right? So let's have a caffeine and conversation. How's that going? In just very informal ways. Right now, I think we're looking to go back old school conversations, even phone calls right now with so much Zoom. I think some of us are getting zoomed out, but the idea that it starts with human connection and it starts with the conversation. So it's very simple, but it's very important. And then you can decide together, what does that look like for that community?
May I bring up something that we talked about in the prep session?
Absolutely.
With the differences in communities,
Yeah.
and how much we each want to relate and support others in other communities. I think I said to you, how can I, as a white man, honor things that I haven't been a part of or been aware of? Can you share with the group the part of that conversation we had, and really equipping groups across communities? Sheila, I love that in the working group, you said there's actually more differences in a community than oftentimes across them. Can you share more about that, Tanya?
Well, I think it's important to, first of all, realize that, we don't know what those are necessarily, right? So going into a community with that sense of cultural humility and saying, I don't know exactly, but I'm here to learn and I'm open and my hands are open to, for you to share that with me. And it's an opportunity to ask questions and be in that environment where it's safe and it's okay to have those conversations, to be, uncomfortable, but to say, how do I, and make yourself vulnerable. And it's really about authenticity and making yourself vulnerable, which is a little scary, but it's really necessary for people to really develop that relational connection as opposed to just a very transactional, because that's really where the transformation happens when you build those connections and those relationships. And that's really a good place to start because we don't all know everything and it's okay. We're here to teach each other.
Yeah, Dave, if I can take a piece of that because it's very, very important. We just had a national discussion on that just recently. Everyone knew the National Geographic decided to do a docudrama on Aretha Franklin. And they courteously, according to published report, asked Aretha family to endorse the project. And then when Aretha family said, we're not going to endorse the project, so let us see the script, tell me all the ramifications of what's going on. And then after we have evaluated that, we will take it. And then eventually Aretha family said no. And then when the actuality went on, this was a big national conversation. Well, Dave, as a white male, we have a problem in the Black community all the time where whites come in our community and tell us what is good for us. Mm-hmm. We've been in this country 400 years. It is no way you can tell me what's good for us. I'm fighting states right now that tells me that the public campaign that they created, even by the ad council, is good for my community. That is the way to get it wrong from the beginning. And what I have done, I told the ad council, they created this portal for the faith community. I ordered my churches not to disseminate that. They didn't ask me. They didn't ask any ministers. They didn't ask our NBC, our educational committee, consists of 3 African-American PhDs that has about 75 years of experience and knows how African-American receive information and how we regurgitate information. They didn't ask anybody. They say, this is good for you. And if the pharma industry continues to do that, it's going to backfire. And another thing that the pharma industry does in terms of clinical trial that we are making sure that they don't do that again is that they come to us when there is the 3rd stage of the clinical trial. They did that exactly for the COVID situation. Both Moderna did it, Pfizer did it, and Nultavic did it. Came to us at the 3rd stuff and say, well, Reverend, can you do all of this? When we present them a proposal, they didn't like the bottom line because they asked us to gather all of these people and we had to persuade all those folks to participate in clinical trials. And when we have done so, they didn't receive it because of the bottom line. So it's a backwards way of doing it. And you're doing it the right way. You're asking right up front, how can I be helpful? How can I reach out? And I would, in the same thing with my sister who's doing this great job in mental health, I want to know how we can integrate our pop-up clinics that we have in the church with her team, because mental health doesn't discriminate. It doesn't really care who you are. So we want people to be served. And the only way to do it is just to make yourself of service like you're doing. So that's a good track. I hope that was not long, but I think you got my point.
Yeah.
I wanted to say thank you so much for bringing that up. This is a thorn in my side, but I concur with you 100%. I actually went back to Ad Council and told them, first of all, do not call us Hispanics. There's only 15% of Hispanics in this country and 85% Latinos. So if you're going to look at our community, talk to the grassroots organization that are working with the Latino community who have been most affected in all levels of even data collection, how it's being reported, how it's being analyzed. I am sick and tired of people telling us who we are instead of looking at us and seeing we're real people. We have real feelings, we have family, we have a lot of issues, challenges, and we're going to work together. They call us later, like you said, we are always an afterthought. And I have been at different people's cases about that. And I applaud Bristol-Myers Squibb for coming to us as an organization, and Pfizer did too. Pfizer came to us and asked us for help. One of the things I also want to bring up is, I don't know how you feel about this, but all of this research on us is totally outdated. It is outdated because they go into these research components, they get all this information, and then about 5 years later, they'll report it, and because it's got to go through all these channels. And we are evolving all the time. We have evolved as a community. We are getting stronger. We're becoming more united. We are letting people know, do not call us Hispanic. And I'll tell you something else. For all of you who are working with informed consents, look at the Spanish translation. I have uncovered, not only is the word for clinical trials is ensayos, and that's a literal term, and that means experiments. And if you're translating subject to an experiment, does that sound inviting to you? And then the other thing is the double negatives. If lawyers really took time to review some of the Spanish translation of some of these forms, or even these websites, they would realize that these double negatives, the health literacy level is at a 12th grade level. And are you ready for this? This is going to blow your mind. When they translate literally demographics, they have Black and African American as negros. And we don't like that term either. It's derogatory to us. And yet all of these forms, demographic forms, we're comfortable with just putting negros in there, never asking us. We would have told them, do not use that word, And then again, this is what we always look at is the fact that we are always an afterthought. They come to us after, when everything is already ready to be published. And that is a problem. And that is a barrier.
Reverend, you said in our earlier conversation how much, despite all of this pain and hurt, you're trying to save relationships and build relationships. And I thought all three of you spoke to that. Reverend, could you just share a bit on that? And then Tanya and Venus jump in. How are you still doing that despite all the frustration?
Well, I'll give you one relationship that we are still trying to save, and that is the relationship with the governors. When it all said and done, and every report is written on COVID, the governors will be the villain here. And the reason why, because the governors are looking at this politically and not scientifically. They are both dispersing the money that is coming down from the federal government and the vaccine politically. This is not a political matter. This is a science medical matter, and we need science people making the decision. And how we're doing that is that the ministers, right now, this minister is holding news conferences across the country, going against the governors, because the governors are using our church for publicity, but giving us none of the vaccines to do ourselves. NBCI, because the governors did not follow their own plan that they submitted to CDC, is backtracking and now doing the political expedient thing to do of using the Black church. Now, we're willing to be used if you are vaccinating Blacks and Latinos. And for the first time, they come into this understanding that the Black church, I told the governors, I'll open 150,000 churches for them. Give us the vaccine, give us the money, let us get this job done. We're trying to save the relationship with two critical groups in society, the ministers and the governors, they cannot go after one another in the midst of a pandemic. So quietly behind the scene, because there's only 37 people, 87 people on the call, we are trying to make sure that the language being used in the public is nothing language you can't take back. So that is a perfect case in point. But at the same time, we are advocating for more vaccine for the African American community. Here in the state of Maryland, we have a governor, another governor, Governor Hogan, says that Blacks do not want the vaccine, as if he is setting us up to give the vaccine to all the white counties and come to Prince George's County, Baltimore County, and Baltimore City last. And that's exactly what's happening here in Maryland, the worst rollout of any state whatsoever. And at the same time, I'm talking about saving relationship, I'm on a call with the state at 3 o'clock trying to save that relationship. So this is a very obvious work on our behalf of trying to do that. I've reached out to the Governors Association and they reached back, but they won't set a conference call because they know what's coming. But I'm trying to reach out to them because I want to avoid what's coming. And I want to avoid African Americans and Latinos are getting in the street demanding the vaccine because we've been overlooked and marginalized and told what to do and how to do this, because they do not know our communities. And one thing my Latino sister just said is that our community, we sometimes don't know our community because our community keep evolving. And so we have to run and catch our own community sometimes. So yeah. I hope that explains it.
Yeah, and may I go right to Tanya? Tanya, what are the best practices, and with how broad NAMI is and the things you focus on, how do you address all those across your work?
Well, I right now, really what we're looking is to really include those individuals that, we're doing things for individuals that we need to include their voice. And as a Latina complex trauma survivor, as a person who's lived these experiences with mental health and dealing with the stigma of our communities, and dealing with the faith communities, and they're really the frontline responders in our communities when we're going to about any type of health issue, mental health issue. And so we're looking to say, nothing about us without us, and we're really bringing those people to the table. And that starts at the community level, and having individuals come out and make those connections and reestablish that trust, because right now there is a sense of mistrust. And so we have to look at, that's been the case, how do we fill that gap? What do we do? And that begins by having these conversations, making these connections. And that takes time, and that takes going into the community and having the right individuals do that. But given the opportunity, people want to do that. They want to be asked, hey, will you come and tell us what are your thoughts? We want to include you in this. And you start at that local level, you start at that community level, so that people feel like we're a part of this cake that we're baking. We're not just put the sprinkles on top or the cake toppers afterwards and here you go. No, we want to be a part of that baking process. We want to be a part of that. We want to say, these are the ingredients we need. This is what's good for us.
Ben on our team, Tanya, says it's not that we want your voice, it's that we can't be right without your voice. If we don't allow people to create the solution from their voice, it can't be the right solution. So powerful the way you framed that. Venus, how are you doing that? And what are the best practices that your team uses?
We have a slogan, misinformation plus miscommunication equals mistrust. If you go to any of us in our community, what are the two biggest barriers is information and communication, because the information is at a level that a lot of people can't understand it. It's being communicated by politicians and people that have no business talking about medicine. And we have decided as an organization, we are committed to our community. So we developed training, and it's free of charge for anyone who wants to get into our website and take the training. We have training on behavioral health, where we look at depression, anxiety, stress, and stigma. And these are issues for community health workers, but anyone who's working in the communities, in the outreach workers, the ambassadors, people working in health ministries can take the training and really get some resources from the training. The other thing, we also developed a clinical trial community navigator. We feel that those of us in the community can really talk to people a little bit more about the whole clinical research aspect and all the voodoo stuff that we have heard over the years about clinical research. Some may be true, but we now have laws protecting our people. You know, they always go back to Tuskegee. Well, it's not just about Tuskegee. It is about what's happening now. And we are still seeing the racial inequities in health and social welfare and mental health. We got to talk about mental health. So that's why we develop these training programs for our community so they can understand and dispel myths about COVID-19, dispel myths and rumors about vaccines, and also look at clinical trials with a different lens and making sure that people know where to go for verifiable information. And we are a trusted source. We've been around since 1997. We're committed to our community, and that's why we're going to continue with the grace of God. Like I said, to me, this is a mission, an answered prayer for being alive after dealing with breast cancer and being a single mom, and then finally being a grandmother. Now I'm committed to my granddaughter, but I just wanted to say that we can all do this together. We should all be united. If you have a special skill, share it with me. I'll share it with the rest of the world, because that's what I do. I plant seeds.
Venus, in our prep conversation, you affected me so much. You believe how much we can do together, and I feel that in everything you do. With just a couple minutes left before we switch to the working group conversation, can we have Reverend Evans just speak to, in a minute or so, what can people do to make a difference? If they want to learn more about you, get involved, what can we do to make a difference together?
Well, we got all of information on our website, www.naltblackchurch.com, all one word. So please get in touch with us and tell us where you are and what your skill set is, so that we can put you to work immediately in our community. Because right now, it is very important, wherever you are, what race you are, that everyone around you and your household be vaccinated. That's the only way we're going to take the next step. Everybody got to be vaccinated. And we are doing everything possible to make that happen. I want to commend my Latino sister Venus, doing an excellent job in getting that information out there. I'm going to join with Tanya in terms of mental health issues, because I'm sure that our churches are right near everything is right. So we're going to pull these things together, because just like you say, we cannot do this alone, but we will stand against institutional, stereotypical understanding of our culture, and we will try in an educational way, and this being one of the most perfect forms to do so, to persuade people that when you do it your way, you're going to cause lives. When you include us, you are going to make sure that all of us live. And just to make sure that they understand this in the English that they speak, if you do it your way, you're going to make just a little bit of money. If you include us, you're going to make a lot of money. So it's good for the bottom line, too.
Good for humanity and good for change. Thank you both. Thank you both for pulling it to purpose. Tanya, what are your closing words, and how can we make change together in all the work that you're doing?
Well, I just first want to say I'm definitely going to set up a caffeine and conversation with Reverend Evans and Venus. I definitely want us to talk about ways we can collaborate. And this is really where it starts, these conversations, and just working together and coming up with ideas, and ultimately realizing that it's all hands on deck right now. We're here for healing, mental health, physical health, and that we all need each other. We all bring our strengths, and working together, we can figure this out. This is a marathon, not a sprint. We've seen everything that's gone on in the last year. And so we need to be here for each other and realize that we are tied together. And if it's okay with you, Dave, I'd love to share that quote that I shared in our call, because I just feel like it really brings all this together. And it's by Lila Watson, who is an Aboriginal activist and a visual artist. And she says, "If you are coming to help me, you are wasting your time. But if you are coming because your liberation is bound up with mine, then let us work together." And I think that really captures what we're trying to do.
Beautifully and powerfully said, Tanya. Thank you so much. If I can ask Ben, just as we wrap up this panel, we have a graphic of all the health equity grantees that are a part of the same group. Can we just show that on the screen for a few minutes? So this is on the COVID Advocacy Exchange. These are all the grantees in this health equity program. If you want to learn more about their work or see what work is being done, this is all now on the COVID Advocacy Exchange platform. And I can't thank you enough, Reverend Evans, Tanya, and Venus, for sharing your time and your passion with us. Thank you.
Thank you very much.
Thank you. So we are going to, I can actually feel, Sheila, I can feel everybody's passion getting ready for the conversations. Just before we make this transition, we have 2 poll questions because we want to gain a sense for where everybody in the audience is now. So we're going to ask you a first question about where you are in advocacy, and then a second question about what matters to you. So if I can have our GRIT team put up the first poll, please, and then we'll give everyone a few moments to read the answers and weigh in. So looks like the largest group is 25% is 2 to 5 years. While there is definitely a group here with 2 decades or more of experience. And it's wonderful to see, boy, 12% desire to, but not yet started. This is your tribe, welcome. And the first year in advocacy is fantastic. So if I can ask our working group leaders to keep that in mind as you go through the conversation, and then can we do just the one other poll before we start that? Wow, not the same difference. So increase knowledge, learn best practices, form connections with other organizations, definitely the top. Identify a place to start making an impact, and unsure but excited to be on the journey. We're all excited you're with us. Thank you. All right, so with those thoughts in mind, I'm very honored to introduce our 4 working group leaders if you haven't met them yet. And if you've been a part of these working groups for the last 2 months, thank you very much. Sheila Thorne, Brad Love, Neil Bertelson, and Gary Nolan will share the progress we've made and then really lead a conversation about what these groups are teaching us and we're doing about them. So Sheila, honored to welcome you.
Thank you so much, David, and welcome and thank you for all of you. I think what we just heard was a very courageous conversation. And those are the kinds of conversations we have to continue to have, even if they make us feel uncomfortable, because in that discomfort, hopefully will come out some change and some recognition and consciousness raising. So thank you for having this session and for being a part of this group. If I may, before I get into the agenda item as you outlined, David, talk a little bit about National Minority Health Month, because many of you may not know the history behind how that month came to be designated as such. I had the privilege in 2002 to be a part of the 16th Surgeon General's advisory group. I was one of 2 from the private sector. And on the agenda for that meeting, he took out some materials that had a lot of dust on them. They were in the archives in the Department of Health and Human Services. And it was about Booker T. Washington, one of the foremost voices and educators in the Black community after slavery, who wanted to establish something called National Negro Health Movement. And out of that came National Negro Health Week. And so from 1915 to 1941, this movement took place. It is the longest running health education campaign in public health history. At that meeting, Dr. Satcher said, it's time to revive it, re-energize it, make it more inclusive. And he gave the charge to that group, who's going to do that? And so 3 of us in that advisory group took those materials and over a weekend plowed through them. And we decided to come up with National Minority Health Month so that it would be also Hispanic, Latinos, Asian, and Native Americans. And that's how it was born back in the day. And we actually wrote a resolution submitted it to Congress, and it is now in the congressional record. So at least once a year, all health information, education executives can take a look at how to focus on these communities. And so I'm proud to be having been a member of that group. So thank you, David, for mentioning that at the outset, and it clearly has taken on a new voice. As far as the work that I have been privileged to do in working with these groups, my focus has been racial and ethnic health and healthcare disparities, something that I've been focused on for almost 30 years now in the private sector. As a woman of color, I saw immediately that these disparities were impacting outreach, contact, and engagement of communities of color. And so I began to focus on that arena, even though in the private sector, working predominantly for pharmaceutical companies. My working group has talked about these issues, and there are several women of color in that group. And so we really gave attention to stories about our own journeys in health as patients. But one of the outstanding takeaways that I saw from these two sessions was the lack of context. You may have a patient that has been diagnosed with a disease or condition, but unless you put that patient in community, you're not going to understand the nature of that journey. And so clearly we talked a lot about how does that diagnosis and living with that disease impact the journey, be it education, transportation, economic stability, food insecurity, and also cultural competency in terms of the healthcare system. So as you have that condition diagnosed, what do you need to do? How does this change your life? How does living as a person of color impact your living with that disease? Especially since the pharmaceutical industry has certainly helped us to go from terminal disease to chronic disease. So it's gone from having the disease to living with the disease. Therein lies the key to success in advocacy, understanding all the steps in that journey. So that was a really key takeaway in my group that helped us to understand exactly how to identify where we need to insert advocacy. I don't know about Gary and Neil, but I'm anxious to hear what you felt about what your groups brought to the fore. Neil?
Yeah, thanks so much, Sheila. Yeah, I'm really seeing lots of parallels with the conversations we've just heard in the previous panel and what we've been hearing within our group and in your group as well, Sheila. So there's this real deep concept kept coming up, which was about being listened to. So our panel was thinking about what is the patient voice, and in particular, how the patient voice can be taken into drug development and clinical trial design and those kinds of things. But it really started with, what do we even mean by patient voice? What is the patient voice trying to express? When we heard from Reverend Evans earlier, that it's, often decision makers are coming to people too late. They're asking their advice after a lot of things have been decided. And in our very first meeting that we had in our working group, that came out really clear. It was like, we are the patients, we have these insights. We really understand what it's like to live with a particular disease, but it's not just our experiences that are important, it's our expectations. What do we want from the future? It's not just about understanding what's happened to us in the past, but where does this lead us into the future? And so we had very similar conversations really about how you get to be in those discussions. How do you get the door open so that your patient voice can be heard? And we had a lot of examples of where that door is still closed. It's still closed to a lot of people. And so a lot of our discussions were around how we can open that door, make things much more open in terms of access to having a voice and being heard, but also creating opportunities of diversity in that voice. So a lot of the same threads kept coming through. Gary, I don't know if there was anything similar in yours.
Yeah, well, equally. So just to give a bit of background, and like Neil and Sheila, I also had the privilege of moderating a group of patient advocates from different backgrounds and different levels of experience in terms of advocacy. The two sessions that I've helped facilitate really had to focus on the future of patient advocacy, and particularly in the wake of COVID-19, looking at how we've had to adapt as advocates during COVID-19, and how we may have to behave differently following COVID-19. And many different experiences, as I mentioned, from a variety of different backgrounds and different levels of experience, as we saw from the poll earlier in this session. One of the striking things that we did first was to try and find a level playing field and really look at what the meaning of advocacy is and what it means to individuals personally and professionally, in order to start to define the future of advocacy. And what we found, although everyone had very different opinions on what advocacy meant, there were some sort of common threads in terms of what advocacy is, and that tended to sit around providing personalized care to patients based on their preferences of what care is, empowerment, supporting patients and their caregivers empower themselves to search for greater treatment options or access to care, then access itself, patient organizations helping with access around new approaches to treatment, new approaches to therapy. And then lastly, the last three, which came up, is patient organizations. Their meaning of advocacy is awareness, research, and policy. So supporting raise awareness of issues and challenges in and around a specific therapy area, supporting research, and then lastly, policy. So helping changes in policy or supporting changes in policy that are important for the patient. So over the course of our workshop, there were different opinions on what advocacy is and what the meaning of advocacy is in order to get to the future advocacy. But although there were differences and different levels of experiences, we came to agree upon these six meanings of advocacy. But what was quite interesting was that as a result of the pandemic, is we've all had to change the way in which we perform advocacy as a patient organization. And we're not, as organizations, we don't all perform the same levels of advocacy. Some groups don't necessarily support access or support awareness. They focus primarily on care. So coming back to these disparities, and it's a bit of a slightly different tangent, but patient advocacy as a term isn't the same meaning for everyone that works in advocacy. So to come back to your point, Neil, is that, even though we use that, and this comes back to a conversation that we were all having last week around our individual meaning of a word, is that, and it came up in the presentations we heard earlier today, is that although we use the same word or the same phrases, it doesn't always mean the same thing. So when we do use the word patient advocacy, what does it actually mean? And trying to understand that I think is important to encourage greater collaborations. And it was another important point that came up in earlier conversations, is that we can't really collaborate meaningfully if we're not all on the same page. And I think that really comes back to a quote from Tanya, which was "Nothing about us without us," and that is a really that sort of phrase struck me in terms in respect to when we talk about all of these topics that came up. We need to go down to the grassroots, and even when we talk about advocacy in this forum, we need to be respectful in the fact that advocacy means so many different things. Is it care? Is it empowerment? Is it access? Is it awareness? Is it research? Is it policy? What does advocacy actually mean? So it's been an interesting couple of weeks, and throughout this next conversation, we can go on to where the group is leading towards where the future of advocacy is.
Exactly.
And some of those points as well.
And our fourth leader?
Yes.
Thank you.
Brad.
Our pattern, no surprise, of course, is similar to what the other teams had talked about. And so I really appreciate everyone sharing that, to know we're on parallel journeys in this way, of course, including, as Gary was just saying, to define terms. The focus of my group is about access to care, broadly speaking. And so just like the notion of advocacy, our dialogue about access and sharing our individual stories where we've bumped into it. have been powerful moments and ways to find common ground and collaboration. Where it appears we're going now, but many people driving this ship, I don't mean to pretend we have a determined direction because there's a lot of dialogue to be had, is wonderfully, I think, looking at systemic issues in access. So as we move beyond the level of the individuals who are affected by and afflicted by, in many cases, the problems of access, starting to hit at a level of why, where this cohort of people, these people with these experiences, all of us, all of you all, experiences and contacts and knowledge, can think about where change lives, because there is lots of knowledge, there is lots of research, there's lots of scholarship, thinking, personal stories in the world about access. We know quite a bit. Where there's opportunity is to come together in the action and to use our personal networks and to use our personal experiences to drive that action. And so that's where we've arrived, and that's where it appears we're going.
You're so right, Brad. And I think all of us agree that this forces us into figuring out where does one insert him or herself into that advocacy process. As the poll indicated, there are some people that haven't started that journey. They're probably asking themselves, well, where do I fit in? You know, what can I do? And how much change can I promote? And that's a very good place to be, because we need everybody at the table. We can't do this alone. And so everybody has to own their space. And that's what I feel many people of color are trying to address as well. Why am I not at the table when these conversations are being had? And if I'm not, who's going to invite me, or just do I put myself in there? So I think Brad and Neil and Gary, I think we're all saying the same thing. This is a collaborative effort. This is something that everybody has to bring something to the table to contribute to the whole. And it's not any one direction. And that word access, Brad, I always struggle with that, because access to many people simply means, do you have insurance? Do you have coverage? And that certainly is critical. But then the question is, once you have that, how do you use it? How can you get the quality care that you deserve? How do you navigate the system and negotiate your own needs? So there are levels to that. And as Gary said, the definitions change depending upon who you're talking to and how you're talking about them. But I'm curious, Anil, this collaboration, what does that mean for you in terms of engaging organizations or individuals? What does collaborate mean? Venus talked about it. She said, don't just come to me with your program. Is that collaboration?
No, that's looking for validation and a tick box, and nobody wants that really. So, no, I think it came out quite loud and clear in our very first meeting that what we're talking about is true collaboration. And collaboration is not just the activity of collaborating, it's also the timeline on which that happens.
Yes.
So the point at which you collaborate should be early enough that the collaboration has meaning, that actually the insights gained both ways in that collaboration can be taken forward into actions. You collaborate too late, even if you do that in a really lovely way, and everybody's very happy with the process, but it's too late to actually make a difference, and it's not true collaboration.
Yeah.
So and the other thing that we talked about in our group was really thinking about this almost as a continuum, a spectrum.
Yes.
You know, not every advocate has all the time to do really deep collaboration and be involved in a lot of full day meetings, but they still want to give their input. So one of the things that we talked about in our last group was really understanding that there are different levels of input and collaboration using mixed methods that could be used to gain inputs from a much wider group of people, a much more diverse group of people. And certainly I think at the moment we're living in a world where we have very rigid systems, where we say this is the collaboration process or the patient involvement process, and it's almost set in stone. And I think we have to start moving towards a world that really accepts and understands that we have a continuum of different inputs and collaboration points. And that's where we started to go in our last meeting.
Yeah, we did as well. And I can't think of any more area where collaboration is critical than yours, Gary, in drug development. I mean, clearly disease burden often drives that, but are there any other areas where we need to have a better collaborative spirit in drug development?
Well, I think towards the end of our last session, we touched on some quite interesting points around drug discovery, drug development, but particularly with COVID-19 and the pandemic itself. Very specifically on drug discovery and drug development and what we've achieved with collaboration. COVID-19 for the first time has seen the titans of industry and pharma working more collaboratively than we've ever seen them working before on developing the vaccine. We've seen research groups working together to rapidly put together diagnostic techniques to identify and measure and track the prevalence of COVID-19 and the R number. We've seen supply chains and supply networks internationally working collaboratively together. And what that has actually resulted in, if we think about what that collaboration has resulted in, well, it's resulted in us rapidly developing and giving access to diagnostic techniques within hours. We've rapidly developed a response and a treatment and a vaccine to the pandemic. We've rapidly shipped it out to millions of people. We've created access overnight. Me sitting in the UK is one of the most challenging countries to get access in the modern world. But we saw the UK being the first country to provide access to the vaccine. And we continue to see the benefits of collaboration in the face of COVID-19. And it's a great example of drug discovery and drug development that if we do collaborate on a broader scale, anything is possible, whether it is around drug discovery, drug development, policy, access. The list goes on, and it's a fantastic example of the power of collaboration.
Indeed.
But I think coming back to the point, we need to define what collaboration is. Yeah. We had in our last conversation, Sheila, how I define collaboration is slightly different to your definition of collaboration.
That's right.
So the collaboration, I think, and just to really provide an answer to your question, Sheila, is the future of advocacy. Is the future of advocacy the patient organizations being the collaborators, the patient organizations creating the table, it being nobody's table, but it being the table that we invite industry to sit at, we invite patients to sit at, and we invite healthcare professionals to sit at. And the role of advocacy, or the future of advocacy, is in being the collaborator, removing personal, professional objectives in light of collaboration for the greater good. And these are the types of conversations that we briefly touched upon in our last session around what has COVID-19 actually taught us. And it's taught us that anything's possible with collaboration. But we're only 2 months in. There's more to come.
And clearly, I think you hit on some of the issues. And Venus brought some up, too, in terms of the systemic issues with regards to drug development that need to be addressed and to look at, for whether it's informed consent documents, whether it's protocol development, exclusion, inclusion criteria. All of those things are systemically in place for good reason, but not sure whether they've always looked at this through a multicultural lens in terms of how people from different race, ethnicities, gender identity. I mean, all of that stuff is not necessarily embedded in that collaborative conversation, and it should be. And that's going to be a challenge because systemically it's hard to move those things with IRBs and FDA and all of those regulatory agencies that are there for a very good reason. But sometimes it may not incorporate the race, ethnicity, gender issues that people are living with as patients. So it's a challenging situation.
Agree.
And Brad, I'm curious to what you think about that and future of advocacy. How can we penetrate that world and make a difference?
I'd like to, if I may, come back to something you brought to us a few weeks ago. Everything you say about obviously those protocols, those systems, all of that's true. One of the other things to be a great reminder to this essential idea that you brought to our conversation is also on an individual level, the humility.
Yes.
The cultural humility. Those systems don't, and just the human humility, those systems don't change till, and this is one of the real barriers, even when we build better intake or exclusion criteria, for example, or something that's more inclusive, if the people involved don't agree to share some control, nothing actually changes because they still apply them in the old ways.
Exactly.
We just find a new tool to produce the same outcome. So to the question you just posed, to me, that's a really key starting point, is to get people who have the privileges, who have the agency in situations, to become more comfortable because they have to. It's the ethically right thing to do. It's the best everything to do.
Exactly.
It's the only thing to do, as a matter of fact.
Exactly.
It is to learn to share that control.
And I think that, I think that comes back to putting your own personal objectives to one side, to allow other objectives become more important in the conversation. And it was mentioned earlier around the bottom line and the financial upside of what a lot of these conversations sit around is. And I go back to the COVID-19 point. There was a race to find a vaccine. Was that for the greater good, or was that for a financial upside? Regardless of that, we got where we need to get to, but the collaboration was definitely that we saw was put some of that financial aspirations to one side. So when we start to see some of our what has been traditional and systemic in drug development around first to market, first mover advantage, all of those things, when we put those things to the side and think, no, we need to do this for other reasons than the bottom line, you immediately, collaboration is so much easier.
Oh yeah. Yeah. Definitely.
And it's about finding those things as well, to Brad's point, finding the things that aren't, as the bottom line is a good example of one. If we can start to leave that to one side and look at other things that are similar to that and we leave them to the side, collaboration becomes organic.
Exactly.
We're not worrying about our personal objectives.
Yeah, I like to call it enlightened self-interest. You can make money and serve society. The two are not mutually exclusive. So you've got to figure out a way. And Neil, you like that, huh, Neil?
Yeah, I do. And I think there's always a sweet spot, no matter how divergent two stakeholders are. There's always a sweet spot where you suddenly realize that you do have common aims. And that's the place to start from. But I just wondered, Sheila, if we should go to poll question number 6, which was asking people who they for their work in your advocacy work today, who you think is important that you need to collaborate with, to give us a sense of where you see those collaboration opportunities.
Great segue. Let's do it.
And while we're waiting for people to finish that, I think that was a really interesting discussion that was prompted by Brad's intervention there, of thinking about, how we think about these stakeholder groups and how we think about collaboration. And I think, both you said it well, Sheila and Gary, that when we even say the word collaboration, we might mean different things. And what is collaboration to one stakeholder may be very tokenistic when viewed from another stakeholder's perspective. So there needs to be a really open conversation about this. And I think there's also some geographical differences about language as well. It really reflects, I was running a workshop several years ago where we were talking about patient value. So what's valuable to a patient with a particular disease? And it started off fine. Everybody agreed that this was important, this was important, this was important. And these patient groups, some were from the US context and some was from a European context. And then suddenly there became a great difference of opinion about whether the value was individual value to a person or whether value was societal value to a group of people with that disease. And suddenly you realize that people were using these value terms, but they were having a different context behind the value terms. They were thinking about it either as an individual or thinking about all people with that disease, which changed the whole nature of that discussion.
Oh, it had to. What's the saying? You see things not how they are, but how you are. So it really is where you come from. Okay, here are our results. Look at this. Wow,
yeah.
Interesting.
It's interesting. The medical communities is just pipped it, and
high numbers. Yeah. Mm-mm-mm.
And the payers higher than the regulators. So
Isn't
you
that
can see
interesting?
here, you
Yeah.
can see here that actually this access question or just being able to get hold of
Yes.
medicines is such a key topic these days.
Indeed. Medical
That's-
community and medical societies is the highest. Interesting.
I also think, and this is something that came up in our workshop, and the point one is forming relationships with advocacy groups outside of your therapy area. We within advocacy and within patient organizations, regardless of what therapy area you are committed to, the challenge is often the same, whether that's around funding, project delivery, et cetera, that there's common themes. So it's I'm not surprised that 73% of people would like to see, and build greater relationships and collaborate outside of their own therapy area, because there are tremendous learnings that can be taken from one area to another.
Indeed. But you remember when we had this conversation, gentlemen, that we also talked about a neutral convener. Who can bring these groups together? Who doesn't have a vested interest, either from the pharmaceutical perspective, the payer perspective, or whatever? I'm not a clinician, so who is the ideal convener to bring everybody to the table who really have the same goals? They just have very different ways of going around doing it. Brad?
Yeah, I thank you for bringing this back up. Goodness, and obviously so much to talk about. But I do think this is maybe, here's a hypothesis, here's the first go at the question, that I do think this is where someone like the Reverend comes in the sense of shared mission. Human thriving is what the Reverend is after. Human well-being in the very global definition, both uppercase and lowercase global definition, that doesn't have a stake in the sort of finances of it, if you will. It has a stake in the humanity and the ethics of it. And
absolutely,
that may be a place to build from.
I think you're right. The faith community, certainly from an ethnic perspective, has been a kind of a foundation for conversation. We're talking about humane medicine. We're just talking about good science. No matter what color it is, no matter where you've come from, So I think we've got to get down to brass tactics. And I think many in the healthcare industry, certainly professionals and providers, they took something called the Hippocratic Oath, I do recall. So, first do no harm. And even if you unconsciously were, you'd want to be told so that you could make a change to be transformed. So I think we just got to get back to brass tactics. Why are we in this business? Is it just bottom line driven, or is it about more than that? Yeah.
And I think to add to that, Sheila, and Brad's point as well, is that is who should this middle collaborator, we call it, be? And I think I think the answer may have come up in the top end of this meeting. It's an individual or an organization that is willing to learn, willing to put themselves in a place of where they're uncomfortable, and come to it with an approach of very much open-minded. We'll get to the final destination by collaboration. So it's coming to it with, as you say, whether it's around health or some completely impartial. It's about coming to it completely open-minded with no prior or preconceived objectives.
That's key. That's the ideal. One of my mentors used to tell me, don't fight necessarily for consensus. That's going to take a long time. Try to get areas of convergence. Where are you closer together than further apart? Start there and then build on that positive space to kind of get some agreement or disagreement or continued debate. So that's how I try to look at it. You're not going to get around the table and say the same thing.
And you can't keep everyone happy all of the time.
That's right.
So
Sheila, one of the lessons we have here in Europe, one of the projects that has worked really well in this creating a safe third-party space is I don't know if you know about it, if anybody else knows about it, but there's an organization called the Innovative Medicines Initiative. And it's run by the European Union. And basically they act as a safe harbor space where stakeholders can come together, get financing, for projects, and their projects are usually 3 to 5 years long. They have a limited span, then they end. But what's interesting about that is there are stakeholders that find it really difficult, impossible for legal reasons to be in the same room with other stakeholders. Classic example is regulators and health technology assessment bodies often cannot be in private meetings with the industry.
That's a good
because
point.
it can be seen as collusion or whatever. So you need to create these safe harbor spaces, not just for moral and ethical reasons, but also for legal reasons. So there are some models that have emerged over the last few years that I think are worth looking at to see how they can be made more international, more global as a way forward.
Yeah, that's an excellent point. There are some compliance issues that you have to be very aware of. And that certainly in the industry is clearly can be a stopgap and a barrier, but it's just the reality of how we do what we do.
So Neil, just to that point, in terms of some examples just of what these sort of forums might be, are you talking like CAB type meetings, that type of thing? Or I'm just interested to understand your examples of those sort of safe environments.
So UPATI, I mean, we've had UPATI on this COVID Advocacy Exchange presenting before. So UPATI was a 5-year project, which was how do you educate the patient advocacy community around drug development so that they can be upskilled in terms of, giving lots of advice throughout medicines development. Very sensitive area, especially at the time this formed, because there was a lot of concern about the industry working with patient organizations. So you needed a third party to bring this all together. So that was an Innovative Medicines Initiative project. It was a 5-year project that allowed the building of a university level course to train advocates. It's now freely available, open access online. That was all developed under this safe harbor where the industry, the regulators, the patient organizations work together to build the content with academic institutions. So that's one example of that. A more recent one was a similar project called Paradigm, which looked at methods, codes of conduct, contracting, all sorts of quite thorny little issues that cause a lot of problems in having patients and patient groups involved with industry, regulators, and payers, for example, developing frameworks. That was a 3-year project, so a shorter project. But again, that could only be developed by having this safe space where everyone could input without feeling it was competitive. The other lesson I have from that is that organization, Innovative Medicines Initiative, but also patient-focused medicines development, only ever work in the non-competitive space. So they work at the disease area level. They never work at a particular treatment level. And so it means that it makes it much easier for the industry to collaborate with each other as well, because they're collaborating on issues that apply to them all. They're not collaborating in any area that can be seen as competitive. And that really helps as well.
It certainly should. Let me just take this diversity conversation that we've been thrust into by COVID-19 like we've never been before. We went from diversity, equity, inclusion, now to belonging. And I think we're talking about that when we speak about collaboration. It's one thing to get enough people of color in terms of the numbers, diversity, inclusion, making them feel part of the team, equity, making sure that everything is fair, but belonging is a challenge. How do I feel valued as a person of color, or am I just being an afterthought that is brought in to make it look right? So if these organizations want to get together, do they feel like they are valued, and do they belong? And how do you sustain that connection? So I think what we're talking about here is you got to have some unusual suspects at the table. It's not the usual people that we're used to talking to. It's got to be some folks from the outside who have a very different point of view and who may stimulate a very different conversation that is needed. So I don't know, David, do you want to do the last polling question to see how people are?
Perfect timing on those two topics. Yeah.
Okay.
We actually have 2 left.
Okay.
Yeah. So could we do Ben or Jess, whoever's queuing up the next one? Could we bring that up now? Thank you, Sheila.
I knew it. Thanks to you and this group, I think that illustrates that one being the most important. Yeah.
I think also just to go back to, and wonderfully, as Dawn pointed out in the chat, that's another data point for belonging of leadership.
Yes.
Belonging right within the larger group, and sort of, as we say, for the 66 people on here, this is our tribe.
Yeah, that's it.
We're going in the same direction.
Yeah. Well, what does the African proverb say? It takes a village.
Yep.
So, so the last question now we want, the last polling question? Okay. Oh, yeah. Mm-hmm. Good stuff.
Is it safe to say we could talk for hours, but we should step up?
Yes, it is safe to say.
Thank you. Without ending it too abruptly, for any of our 4 working leaders, any final thoughts, or how is this process for you leading these groups?
It's been energizing for me. It's been encouraging and it's been motivating, because sometimes advocates who have doing it for a long time feel like they're out there by themselves and they need this kind of conversation to keep them stimulated and motivated to keep on keeping on. So for me, that's what it's done, very much so.
I'd echo that. I think, sorry, Neil, just supporting conversations around areas that aren't naturally discussed, and identifying common ground and areas for future opportunities has been fascinating. And as you said at the top of the meeting, Dave, hopefully we will, at the end of this process, actually be able to present and deliver some meaningful resources, materials, outcomes that will be adopted in future advocacy activities. And that's it's exciting to be part of those conversations. Sorry, Neil, I cut across you.
That's fine. That's fine. And I think it's similar in our session. I think we've been really engaged around this idea of how do we not just make our voice heard, but ensure that action is taken on our voice. So I think there's a lot of things. We have to think about language here. What do we mean by patient voice, which is part of the title of our session? And it's no good having a voice unless the voice is not just heard, but action is taken based on that. So there's been a lot around how we get our voices heard and how we understand that action has been taken, that feedback loop, what are the principles behind that. So I think I felt very energized by the discussions that we've had within our group. And it's really some very, very fundamental questions that people often gloss over. And so I'm really glad that we're going in this direction in our working group.
Good stuff. Good stuff. 10 years ago, this meeting would have never happened. So the fact that we've moved to this point in conversation is very encouraging. It's gone from why should we do this to now how do we do this? And I think that's a good place to be.
Yeah, and we'd love to welcome everyone back. So our next session together is May 13th at 12 noon Eastern. We will go back into the working group format next month. So each of our leaders will take us back into the working group to continue the conversations. To me, what today really embodied is what you identified from the takeaway so far. There's a continuum of advocacy.
Yes.
And making sure, Sheila, I think you said last time, people are at different knowledge, availability, willingness. And the more we think of this as a continuum, the more we can create change together.
Absolutely.
Working group leaders, thank you. The BMS champions who are driving all of this with us, the GRIT team and EvokeKind team who are making all this possible, and everyone who is such an invested part of these conversations. Thank you, and we'll see you next month for much, much more.